Hello, everybody. Welcome to Grand Rounds. We're happy to have you with us. Our special guest today, Dr. Jawad Ahmad, who is a professor of medicine in the Rekanati Miller Transplantation Institute at the Icahn School of Medicine at Mount Sinai, where he has been studying biliary complications after liver transplantation, PSC, and drug-induced liver injury, which is what he's going to be talking to us about today. He's the co-director and co-primary investigator of the NIH-sponsored Mount Sinai Drug-Induced Liver Injury Network since 2013. Dr. Ahmad, welcome.
Great, thank you so much for the introduction. Let me share my screen. You can see my screen?
Not yet.
Not yet.
Oh,
There we go.
okay, very good. All right, and let me just
Which is into, yep, exactly. Perfect.
let me just. Okay, so as Dr. Weissman mentioned, so this talk will be about drug-induced liver injury. My name's Jawad Ahmad. I do this in conjunction with my co-director, Dr. Joseph Odin, and we're both at the main campus. So I have no disclosures. So just to give you an outline, we'll talk about drug-induced liver injury and what the DILI network does. We'll talk about epidemiology, a little bit about genetics and causality, and then maybe in the last 10-15 minutes, we'll talk about herbal and dietary supplements. So we talk about drug-induced liver injury, but this can be from prescription drugs, but also from things that people take, which they wouldn't necessarily classify as drugs, because there's some interesting data on this. So we'll start with the case. So this is, unfortunately, a real case. This is a 28-year-old male, comes with several weeks of kind of initially non-specific symptoms, some weakness, maybe fatigue, but then gets dark urine, pale stool, and he gets jaundiced. No real past medical history, except he was overweight and he was trying to lose weight by taking, by exercising, watching his diet, but also taking multiple herbal and dietary supplements. And they were working because he lost 120 pounds over 6 months. He's a smoker, no alcohol, no drugs. When you examine him, he's jaundiced, but he was alert and orientated, no liver flap, his abdomen was soft, and no hepatosplenomegaly. So his initial labs are shown here. The workup for acute hepatitis was negative in terms of viral markers, autoimmune markers, metabolic markers. And you can see he's got a severe injury with jaundice, right? So he has an ALT and an AST of 1500 or so, really no alkaline phosphatase, but evidence of liver synthetic dysfunction, INR 2.7, creatinine was normal, and his jaundice, the bilirubin is 33. So talk for another day, but this qualifies as Hy's law. Hy Zimmerman was a very eminent liver pathologist. So if you see hepatocellular injury, meaning very high transaminases with jaundice, there's significant mortality associated with that. That's what Hy's law says. So this gentleman, we admitted him. Unfortunately, he worsens. His INR rises. He develops a liver flap. We list him for liver transplant as a status 1, so that's the top priority. And he thankfully underwent transplant a week later. And on the explant, what you see is what you'd expect: massive hepatic necrosis. And the pathologists say consistent with a history of drug-induced liver injury. Now, I take that with a grain of salt. Anybody who's any pathologist listening, we can talk about that offline, but I'm not certain you can actually say that someone has drug-induced liver injury just on a liver biopsy. The patient actually did well after transplant, and when he did get better, eventually he brought in his weight loss program. So these are all the things that he was taking. So maybe 15 or 20 different compounds, and of those compounds, they're going to have maybe 20, 30 ingredients. And we'll talk a little bit about it later on about, well, how do you decipher which of these compounds was the thing that caused his liver injury? Can you actually do that? So we'll talk about that a little bit later on. So the DILI network is been around for almost 20 years now. So this is an NIH-funded U01 cooperative agreement. So that basically means that you take centers throughout the country, similar to Mount Sinai, who are interested in this and have PIs at each one, and then we essentially collaborate. We collect the cases. So the main aims are to advance understanding and research into idiosyncratic DILI. I highlighted idiosyncratic because this is not, we're not really interested in, for instance, acetaminophen liver injury. Right? So acetaminophen is a predictable liver injury. You take too much of it, you're going to get liver injury from it. We're interested in idiosyncratic, right? So that means there's really no rhyme or reason why this person got this injury from this drug at this time. There's a prospective registry. So this is patients that obviously we're collecting as the injury happens. Also a retrospective arm to the study, which hasn't recruited that many, but let's say you have a patient that you knew 10 years ago was transplanted and had a liver injury from eyes and eyes, let's say. We're also interested in trying to standardize kind of the nomenclature for this, right? So this isn't an area where there's a blood test that can prove the patient has DILI. So making a diagnosis and establishing causality is actually quite difficult. We'll talk a little bit about that. So in the 20 years, I would say that there has been some progress made in these kind of aims. So currently we're on the fourth iteration. There will be a fifth, starting hopefully 2023. And the sites are listed there. So kind of northeast preponderance, although a little bit of Midwest, you can count in Indiana and Michigan, and then one site over on the West Coast with USC, UCLA. The aims of this iteration, right? So this is the way these UO1 studies work, is that you get funding for 5 years. So this is the fourth iteration. So it's 2018 to 2023. So essentially expand the registry of patients that we already have, identify kind of risk factors, clinical risk factors, but also maybe genetic risk factors. Now, this is something that will be very important, hopefully going forward, is that if you can identify why this person got this injury from this drug because they have a genetic risk for it, that would be very useful. Maybe there's an intervention that we can try, right? So some of these injuries are actually pretty severe. Is it worth trying something to treat DILI? So we have a study which hopefully will start soon on that. And then another thing that we're usefully positioned to do would be pharmacovigilance. And I'll show you one example of that, meaning particularly with the herbal and dietary supplements, right? So these things, new compounds are coming onto the market all the time. What about a new compound that comes and then is suddenly causing liver injury? Maybe we can be a bellwether to pick up these injuries before they become a real problem in a bigger patient population. So I'll give you one example of that a little bit later. So in terms of what we currently have recruited, this slide's a little bit old, but the N is written up there. So we have about maybe 2,500 patients so far that we've got clinical data on. We have stored sera, and we have very good characterization. So these are all patients that had a drug-induced liver injury. So in terms of kind of just demographics, you can see there, they're kind of middle-aged, a little bit of a female predominance. Mainly Caucasian. That's something to do with, we joined the cooperative agreement a little bit later, but like Indiana or Michigan and places like that typically will have Caucasian patients. These patients are actually quite sick, right? So I'll show you a slide a little bit later. When we talk about DILI, there's like this whole spectrum, right? You can have patients that have just kind of mild abnormalities of LFTs, but other patients, like the case in this particular presentation, who had a very severe injury. He was jaundiced, right? So we have a tendency to recruit patients that are a little bit sicker than you may anticipate just with a regular DILI, because 2/3 of our patients are jaundiced. Sometimes there's a fever and rash. Maybe there's an immunoallergic phenomenon going on here. And then the pattern of injury is useful. So we split it into what we classify as hepatocellular, cholestatic, and mixed. Right, so the initial injury that I showed you in this case, this was a hepatocellular, right? You had very high transaminase, but sometimes you can get an injury where the alkaline phosphatase is elevated rather than the ALT and AST, and sometimes there's a mixed picture, and there's a ratio that you can actually use to calculate that, and it's useful because some drugs give you a certain pattern of injury. Some more characteristics. So again, as I mentioned, there's a whole spectrum of illness. So the ALT and AST and alkaline phosphatase I'll show you at the onset of the injury, and sometimes later on they get worse, right? So sometimes the patient, we pick up the injury and they're a little bit jaundiced, but they get more jaundiced, meaning the injury gets worse. And this doesn't have an entirely benign outcome. You would think that, well, this is a liver injury. You get a little bit jaundice, you get liver enzymes that are elevated, you stop the drug, patient gets better. Most of the time that happens, but sometimes it doesn't, right? So here's outcome measures. 7% of the population die, right? Now, you can argue, well, that's kind of that's high, but maybe that's not a true figure because some of the deaths occurred for other reasons, right? So some patients had cancer and were on a chemotherapy drug that caused DILI, but they ended up dying of the cancer, not the DILI, right? So of the 7% death that we see, about half are liver related, right? So maybe 3.5%. So again, it's a high figure, it's a bit of a concern, but it also speaks to the fact that we tend to recruit patients who are sicker. We tend not to recruit patients that have a kind of a milder injury. And you can see that because most of the patients that we recruit are admitted to the hospital and some of them end up getting transplant. Now, chronic DILI is a talk for another day, but this is important. What it shows is that some patients, they get an injury that's an acute injury. The drug has incited some sort of injury to the liver, but it doesn't get better, meaning they stop the drug, but 6 months later, they still have evidence of liver injury. And we also have FibroScan data on this as well. And as I mentioned, a talk for another day. But the figure to remember is that maybe a fifth, so maybe 20% of patients will get chronic DILI, meaning an injury that does not get better. As I mentioned, we're interested in idiosyncratic DILI because they're the things where the injury is not predictable. So it affects only, it's an uncommon injury. It affects patients that are presumably genetically susceptible. It's not really dose dependent, or it's less dose dependent. It probably is a little bit dose dependent in the sense that the more you take, the more likely it is to happen, but it can happen even with a low dose. And the clinical course is more variable, meaning, as we know with acetaminophen, you overdose on acetaminophen, it's a very predictable response what's going to happen, as opposed to with idiosyncratic DILI. Chronic DILI I already talked about. Latency is important. It means the time from when you started the drug to when the liver injury happened, right? So this is important because is it reasonable to think that you've been on a drug for a year, let's say, nitrofurantoin is a good example, right? An antibiotic that's used chronically for suppressing UTIs. Can you get a liver injury after you've been on a drug for a year? So the latency is important. How long did it take for the injury to appear so that you can assess the causality? De-challenge basically means how long did it take for it to get better, right? You stop the drug, how long did it take before the enzymes normalized? So let's talk a little bit about epidemiology and risk factors. So I mentioned a little bit earlier, right? You can think about this as a pyramid. So if you talk about DILI as being kind of elevated liver enzymes on a drug, it's going to be millions and millions of people. So the best example is maybe statins, right? Statins are well known to cause mild elevation of liver enzymes. Whether that's clinically relevant or not is open to debate. But as you go up the pyramid, you're going to start getting patients who are sicker, but there'll be a lot less of those, like the patient that I just presented, who can get jaundice with liver injury, but then also get acute liver failure and then die, right? So if you look at some of the figures, just if you look at the bottom of the pyramid, it's millions of people every year. And I'll show you some data from other countries as well. But if you look at the top of the pyramid, thankfully, it's going to be a lot less. But if you look at hospital admissions, right? So for us over at Sinai, we have 3 liver services, right? So we have a pre-liver service, a post-liver service, and we have a consult service. I would say more than half of the patients that we see in the consult service are abnormal LFTs, right? In an orthopedic patient or in a cardiac patient. And most of those are going to be DILI. And that's backed up by data showing that a lot of hospital admissions, not alone what we see on the consult service, a few percent of hospital admissions are probably DILI. If you extrapolate that to patients that have bad liver injury, acute liver failure, get transplanted, it's several hundred patients every year. And as I mentioned, the Hy's law. It's caused by prescribed drugs, but the herbal dietary stuff is something that is topical, and we're seeing a greater incidence, I would say, in the last decade or two, because more people are using these things. There are already specific kind of risk drug associations, right? So we know that, for instance, INH is an age-related thing, right? You guys will know even better than me, maybe. That there's kind of an age cutoff for latent TB when you should be using INH. There's a similar thing with valproate. It's kind of a drug that you've got to be aware of in the pediatric population. And there are other risk factors: gender, more women are likely to get diclofenac injury, obesity, pregnancy, HIV, polypharmacy probably plays a role. So the more drugs you're on, so that means elderly patients. And then SIP status also is a risk factor for certain drugs and DILI. There are other things that you can look at to predict DILI other than just like cytochrome P450 status. So are there specific polymorphisms that you can identify for certain drugs? So there are. So I've listed some of them here, and then I'll show you some Jawad studies. So essentially what this means is that if you have this particular polymorphism, it increases your risk of an injury from this drug X-fold. So for instance here, HLA, that seems obvious, right? HLA is part of our immune system. If you have polymorphisms in HLA, and remember there's lots of different HLA haplotypes, it makes sense then when you do these GWAS plots, these Manhattan plots, that you'll see a spike on chromosome 6, right? So this is for two different drugs. Flucloxacillin is an antibiotic used in Europe, and terbinafine is an antifungal agent. You can see there's a spike, the red spike that's seen on chromosome 6 corresponds to the HLA gene. So HLA B5701 increases your risk 80 times of having an injury from flucloxacillin, and similarly A3301 increases your risk 76 times with terbinafine. This is clinically useful data, but remember these are injuries that are not that common. So even though it increases your risk 70 to 80-fold, is that enough to be doing genetic testing on anybody before you give them terbinafine? Probably not, right? Because it's still going to be a pretty uncommon event. We've also been working on not just HLA associations, but other genes that may influence your immune response to this particular drug. So, for instance, this PTPN22 is a gene that codes for a protein tyrosine phosphatase that's expressed in lymphoid tissue. But if you look at this gene and look at polymorphisms in this gene, it affects responsiveness from B and T cells, and it therefore is involved in various kind of autoimmune type diseases. So I've shown on this cartoon, it's associated with things that you typically think are obviously autoimmune disease, Addison's disease, Hashimoto, Graves' disease, myasthenia, etc., but also DILI. So we published on this recently. So this is in Gastro from a couple of years ago. So it shows that you can see the spike on chromosome 6 that corresponds to the HLA. So this is 2,000 cases of DILI. And you can see there's also a spike on chromosome 1 that corresponds to this PTPN22 gene. So what does this actually do? Well, I'll give you one example. So augmentin is a commonly used antibiotic that we see drug-induced liver injury from pretty commonly. So if you look at augmentin, there are HLA risk factors for augmentin liver injury, but also this PTPN22, it seems to augment, deliberate pun, the risk of getting liver injury from augmentin. So I've highlighted in yellow there that if you have DRB1-1501 and A0201, they're risk factors for getting augmentin DILI. Not the same as the sets, 70 to 80-fold that was shown in those other two drugs, but maybe an odds ratio of about 8. But if you also have PTPN22, it kind of doubles your risk. Whereas if you don't have the HLA risk factors, the PTPN22 doesn't really do anything. So it's a modulator of genetic risk factors. And there's a couple of other things that we've been working on that do similar things. But the upshot really is that, yes, going forward, it's not like TPMT, right? So people who use azathioprine, right? When we know that guidelines, depending on rheumatology or gastroenterology, whoever used those drugs, suggest that you should be doing TPMT testing beforehand because you don't want to get neutropenia from azathioprine if you use too big a dose. We're not there for DILI. Right, so there's no clinical utility yet for doing genetic testing, even for the flucloxacillin that I showed, or for the terbinafine. INH maybe, right? INH we know is a pretty common cause of drug-induced liver injury, and maybe it would be worthwhile doing in that patient population if you could identify HLA risk factors. But in general, the incidence of DILI is too low to be doing it based on what it would cost and the effort to do all this. But it will change if we have stronger risk factors, and obviously the cost of genome sequencing goes down pretty much every month. So let's switch to diagnosis. So we have a patient that has a liver injury, and how do we say, well, yeah, we're pretty certain this is what caused it. We think this drug caused it. So One of the things we use is initially, well, how bad is the injury? So you have to look at the criteria for a clinically significant event. So in our network, this is what we use, and this is a little bit arbitrary, but most other networks in other countries do something very similar. So we look at the amount the ALT is elevated and how jaundiced the patient is, and the amount the alkaline phosphatase is elevated. So we use 5 times here for ALT, AST, and 2 times for outphos, and 2.5 milligrams per deciliter for the jaundice, for the bilirubin. Spoke about this a little bit earlier. The R ratio is important, right? So we talk about hepatocellular, cholestatic, or mixed, and it basically reflects how high the transaminases are versus the alkaline phosphatase. So hepatocellular has predominantly a transaminase elevation, cholestatic has predominantly alkaline phosphatase elevation, and there's a mixed number. So we use the R ratio based on this calculation. The problem is some drugs, yes, classically cause a cholestatic injury, but they can also cause a hepatocellular injury. But it's useful to know what was the injury initially, so you can be, how certain can you be about the diagnosis. What we really do, though, is we use other tests to exclude other things, and then if we're left with nothing else, then it's probably DILI, right? So you want to make sure the patient doesn't have hepatitis A, B, C, or E even. Biliary disease, if it's cholestatic, that makes sense, right? If you have PSC, that can mimic, I suppose, DILI. So you should be getting an MRI. Ischemic congestion is pretty easy to rule out, right? If you're on if the patient's had a AAA repair yesterday and now has very high transaminases, it's likely to be ischemia. Alcoholic hepatitis really shouldn't be an issue. I mean, the numbers really don't get that high in the AST, ALT plus the history of alcohol. Autoimmune liver disease with the markers, yes. And then you really do need to ask about what did you take, right? The problem with the herbal and dietary things, and particularly over-the-counter things, is that patients don't volunteer that information. So you have to ask them, okay? We've had a couple of cases where people didn't even take anything. They probably inhaled it, or it was topical exposure. So for instance, hair dye. So you have to really be very, in terms of the history, maybe the medical student is the best person to get the history out. What on earth did you get exposed to? It's useful to check for hepatitis C RNA. That makes sense, right? If a patient has acute hepatitis, you would think, well, maybe they've got a risk factor to get acute hepatitis C. When we've looked at this, patients don't need to have a risk factor. So you need to ask, and you need to then test. Hepatitis E, we have a big study looking at this. So we've got stored sera. So when we first started doing the study, we didn't have good testing for HEV. Now we do. So we've gone back and looked. And yeah, not surprisingly, some of these patients we thought had DILI, pretty classic DILI, and yet really it was hepatitis E. And then testing for kind of atypical viruses, they're pretty uncommon, and usually there'll be a clinical presentation that will show that. We talked about doing abdominal imaging. That makes sense, particularly for cholestatic diseases, and maybe less so doing an ERCP. We just published this a couple of months ago. What about doing a liver biopsy, right? So it seems to make sense. If you have a liver injury, you did all the testing, everything's negative, maybe a liver biopsy will help you in determining whether this is DILI. So what we did here is a little bit of a difficult study to explain, but essentially the message is this, and I'll just show you the graph. So these are 5 categories of patients that we see, right? So we think this patient had a liver injury. Do we think that the injury was definite, highly likely, probable, possible, or unlikely? So we're using a 5-point Likert scale. So basically, definite, highly likely, and probable, we think a DILI, but possible and likely, we don't think a DILI. So the orange bars are prior to the biopsy. So you see the cases kind of cluster in the middle. So we're a little bit on the fence. We're thinking probable, possible, maybe likely. But after the biopsy, it spreads out, meaning a biopsy makes you more definitive in determining whether the patient does have DILI or excluding DILI, right? So sometimes you do it and you think, oh, basically the patient has autoimmune disease, and it was a useful biopsy to do because then maybe that leads to steroid treatment, okay? Assessing causality, right? So you made a diagnosis, but how certain are you that this drug caused the injury? Because sometimes people take more than one drug, right? So if you look at the database, 9 out of the 10 top drugs, right? So what are the top 10 drugs that we see? 9 of them are antibiotics, right? So antimicrobials are the drug that usually we think cause the injury when there's a cocktail of drugs, because it's just more commonly. But that doesn't go into the denominator. Now we have, again, for brevity, I didn't include all this, but it will be useful to know, well, okay, fine, you have 9 drugs that are causing liver injury here in your network, but maybe they're the 9 most commonly prescribed drugs, right? So it's not really that common. It's just because it's a function of those drugs being prescribed so often. That's not true, actually. If you think about which drugs can cause DILI, well, it's basically any drug, right? So I'll show you one slide at the end. If you take nothing else away from this talk, it's going to be the most important one. But if you look in the big, the drug reference book that we have, it always says caution liver disease. It always says caution can cause abnormal liver tests. So I take that with a grain of salt. But there are some drugs that you've got to be careful with. I'll show you a slide a bit later on. But also the herbal and dietary stuff, right? So if you look at the HDS, so for instance, the compounds this particular patient was taking that I showed you earlier, he's taking so many things, but there are some things that stick out that you really got to be aware of, right? So I've highlighted some of those in yellow there. So green tea extract, we just published on this, and this is used by a lot of people. Green tea extract can cause a liver injury, and there's a genetic risk factor for it as well. Oxylete Pro has been withdrawn from the market. I'll show you a couple of slides later about how that had legal ramifications, but also things that are being used much more commonly now than they were before. So kratom, which is a kind of a thing that you can use as a kind of a narcotic kind of replacement. Turmeric, garcinia, and a bunch of other things that I've listed there. If you look at prescription drugs, this is important because the package insert on these drugs tells you need to monitor LFTs. So we know about statins, but fluconazole, for instance, or any of the azoles, isoniazid, we know about ritonavir, nitrofurantoin, methotrexate, all of these drugs you've got to be careful with because there are legal ramifications if you don't, right? So if someone gets a liver injury and you put them on ketoconazole for whatever athlete's foot or something, and they get DILI from this is malpractice. Making a diagnosis also relies on, well, what kind of pattern of injury are we seeing? So there are certain drugs that cause a certain drug injury. So isoniazid and the TB drugs classically cause hepatocellular injury with jaundice. So usually there's not much debate about that. When you see a patient with latent TB on INH have some non-specific symptoms and then 2 months later is jaundice, it's going to be the INH. Nitrofurantoin and minocycline cause like a autoimmune type hepatitis. So that can sometimes be difficult, right? What's the difference between drug-induced autoimmune hepatitis versus de novo autoimmune hepatitis? So we do struggle with that. And then the antibiotics, particularly augmentin, for instance, causes a cholestatic hepatitis. So again, if you get jaundice with high outphos and you were on augmentin, it was probably the augmentin that did it. And I've listed some other examples there. The latency is also important. Augmentin, for instance, you shouldn't be getting a drug-induced liver injury 6 months after being on it. I mean, it's too long. The washout has already occurred. That shouldn't happen. But some drugs can take a long time, particularly nitrofurantoin, to cause an injury. So a little unclear why that happens, but it's something to be aware of. So for us in the network, we do this really for purposes of studies. It can't really do this in clinical practice. But how certain are we that this patient has DILI? So we use expert opinion, right? So every month we meet, we discuss potential cases, and then we decide individually and then by consensus how likely we thought this was DILI. And we come up with a 5-point scale. I'll show you a couple of slides in a second about a computerized method of making this diagnosis. So the RUCAM is some 30 years old now, but it's basically you assign a score based on several criteria, and then the higher the score, the more likely you think it's going to be DILI. I'll show you what that is in a second. So for us, in terms of the network, we use the kind of a legal scale, right? Definite, highly likely, probable. Based on how likely we think this is to occur. If we think it's possible unlikely, then we have to look for another reason. Well, why did this person have a liver injury if we don't think it was DILI? The RUCAM, it's a bit like any other scoring systems people use for to make a diagnosis for other diseases. So, how long did it take for the injury to start? Was there a D challenge? Did you rule out other things? How likely was this drug in the past to have caused an injury, et cetera, et cetera? And then you can get a score based on all these domains, and if it's a high score, it's more likely to be DILI than it isn't. The problem with it, it's like 30 years old. It doesn't really take into account herbal and dietary supplements. So we've just recently published on the RECAM as opposed to the RUCAM. So this is in hepatology from a couple of months ago. And there'll be an app for this as well. So you can put your clinical data into the app and it will spit out a score. And the domains are similar to the RUCAM, latency, D challenge, literature, etc. But if you compare the two, the recam's a little bit better. And as I say, there will be an app for this. In terms of management strategies, so really there isn't much we can offer, right? So the best thing you can do is stop the drug. The problem is sometimes you're not aware that there is an injury until the injury is kind of pretty severe. But stopping the drug obviously makes a difference, because if you carry on and the patient was unaware, then bad things happen. You can mention this. So, NAC or N-acetylcysteine is used as an antidote for acetaminophen liver injury, right? But it also probably works in non-acetaminophen injury. So this is from the acute liver failure study group, and it showed that compared to placebo, NAC seemed to help in non-acetaminophen liver injury. So if you have someone with a severe liver injury and you're looking after them, I would give them NAC. All right, it does no harm, and it might do some good. We're probably going to study this in a better prospective way. But steroids, you would think, okay, so the person has an acute liver injury. There's a lot of inflammation. Let's just give them steroids. At least in the acute liver failure study group, it didn't seem to make a difference. I would say, and we'll hopefully prove this when we do our study, that in a subset of patients with DILI, steroids probably are helpful. But I wouldn't just give them if you're not really certain, because there's a downside to giving high dose steroids. Other than that, there's not much else you can do, right? You can give antidotes to a few examples of DILI, right? So IV carnitine works for valproate liver injury. So pediatricians know this. In patients that have a very kind of immunoallergic reaction, steroids probably help. Sometimes cholestyramine and ursidile work for very cholestatic injuries, and obviously transplant as the case that I presented earlier on. But otherwise, we don't have a lot to offer. So let's switch to herbal and dietary supplements. So these are not classified as drugs, right? So this is why they're available so readily, right? So they're vitamins, minerals, dietary and food components, herbs, natural, whatever you want to call them, that they supplement your diet. So they're not drugs. The problem is they don't really undergo any kind of safety or efficacy testing because they're a food. So it's easy to get. It's always been the fine print at the bottom of the label that this product is not intended to diagnose, cure, or treat any disease, because the manufacturer has to put that in. The FDA has told them that. It's big business, right? So I'm sure this is out of date. 40 billion, I'm sure it's 100 billion of sales for these things. And they're, you see them, they're safe, cheap, natural. So people just assume they're good for you, as opposed to expensive and manufactured pharmaceutical compounds. The problem is natural does not mean safe. So this was published a few years ago. If you look at the compounds that we enroll patients with DILI, I mentioned antimicrobials are the #1 kind of group. The next group is HDS. And if you look what's happened in terms of the trend, the graph on the left, over time, going from the initial iterations of DILI to now, HDS is taking up a much bigger slice of the pie. So we're seeing this even more commonly. Maybe we're just more attuned to it, to ask about it, and maybe it's just to do with the increasing use of these things. If you look in terms of when people have said, well, okay, this stuff is safe and it's being sold for X, Y, and Z, maybe we should look at these compounds to see how safe they are and what's actually in them. So the New York Attorney General actually did this, and we've also done this. So what they did is they went to Walmart or GNC or whoever's selling this stuff, took stuff off the shelves and then analyzed it. And so, if you're taking ginkgo biloba from Walmart, it's basically got powdered radish, houseplants, and wheat in it, even though it's meant to be gluten-free. Same thing with GNC. And so Walmart was cited for this, as was GNC. And as I say, we've done this in DILI. So what we did is we partnered with a guy in Mississippi who, it's a mouthful, he runs a lab that basically analyzes products. So he does mass specs on products and then can give you a printout of what's in the product. So what we did, or what we do is that when we have a patient like the patient that I presented, when he brings in all the stuff that he took, we collect that stuff, we send it to this guy in Mississippi who then analyzes what's in it. So if we look at that as a group, we did this a few years ago now, we took 337 samples of HDS that we had collected from patients that had DILI. And we analyzed, okay, what were they used for? But we also analyzed the ingredients. And so what we found was that half the time, what's labeled is not there, or there's extra stuff that's there that's not labeled. So this is a potential problem. So what are the things that we look for? We look for things that can cause liver injury, right? So anabolic steroids are a classic cause of a kind of a bland cholestasis. So we look for those, particularly in supplements that are used for, weight training or bodybuilding, etc. Also for weight loss. But there are other things that we're looking for, including pharmaceuticals, that might be in this natural product. I'll leave this one, but I'll go on to show you an example of mislabeling, right? So this was a 24-year-old man comes in with an acute icteric hepatitis, right? So high transaminases, jaundice, and he'd been taking a bunch of products for muscle gain. So they included, and they always have kind of exotic names, Nano Vapor, Animal Flex, Optimum, Opti, etc. One was called tamoxifen. So here's the pattern of injury, and you can see that he has kind of a mild kind of transaminitis. Alphos is normal. He gets jaundice, and then eventually kind of recovers. And we took the products that he was taking, including this tamoxifen, and you can see here the ingredients for tamoxifen are listed there, and ND means not detectable. So all the ingredients that were listed there were actually not in the product. And here's our mass spectrometry. And you can see there's a spike of something showing up. And the spike that shows up, actually, is tamoxifen. So this person was taking tamoxifen, which allegedly had all these ingredients in it for his bodybuilding. But in fact, it had tamoxifen in it. And that corresponds to the injury that he had corresponds to the liver injury you would get from tamoxifen. So there's an example of mislabeling and also contamination or adulteration. This happened with OxyElite Pro. So we were involved in this and we published on this. And after we published on this, we got subpoenas from the manufacturer of this compound, kind of cease and desist type subpoenas. We didn't cease and desist. And what happened with this compound was that a bunch of people, unfortunately, got sick from taking this for weight loss because it had DMAA, this dimethyl amylamine in it, and it caused multiple episodes of liver injury, death, and liver transplantation in Hawaii, in military, right? Because the military use this stuff for weight loss as well. They published on it, and we published on it. And eventually, the government got involved, and this company and the directors of this company pled guilty and are imprisoned. We also published on kratom. So kratom, you'll see this, when you look at the National Poison Data System, they're seeing a dramatic rise in kratom poisoning, right? Because this is a substitute for narcotics. You can buy it. This is CBD oil and kratom stores. Because it's readily available. And we published on this, and it shows that similarly with the increase that the National Poison Data System is seeing, we're seeing an increase in the networks. Makes sense. The more people are using it, you're going to get more injury. Running a bit short on time, so I want to finish up. So this also we just published recently, green tea extract. You would think this is great, right? Green tea extract, good for me. But what we showed in this paper is that maybe not so good for you. So this was around about 40 cases of patients that we enrolled that had liver injury that we felt were from green tea extract. And you can see typical female predominance. A lot of them got jaundice, high transaminases, and almost all of them were, as I mentioned, hepatocellular. But what we also did is then we looked at the HLA association. And this is important, a little bit of a difficult slide to interpret, but I'll try to explain it. What it shows is that in the cases that we really felt were green tea, we weren't, on the fence. We felt this is definite green tea injury, versus if we were a little bit more on the fence, versus if we were kind of, okay, maybe it is, maybe it isn't. The more we felt it was a clinical injury from green tea extract, the more likely you are to have HLA B3501. So what this shows is that this HLA haplotype is strongly associated with injury with green tea extract. And you'll see, again, the next iteration of the network will hopefully enroll some more patients, and we'll be able to identify more HLA haplotypes as well as other genetic risk factors for DILI. So just to almost wrap up, so the current and future projects, hepatitis E I talked about, and this is important, and this is one of the reasons we store sera, because we may have a patient with an injury which we don't have a test to pick up another alternative diagnosis on. So we're looking at all our cases to see if there was hepatitis E infection. Garcinia is kind of similar to green tea extract, something that's used pretty commonly. Genetic studies, I talked about the PTMP22, there's things called ERAP1 and 2 that modify your risk. I talked about the RECAM. So there, as I mentioned, there'll be an app hopefully later this year that you can get, that when you have a liver injury, you can put it in and see if the RECAM score is high. We're looking at some other things about Hy's law. We will hopefully start a trial of steroids in severe suspected DILI, and this will be all in DILIN 5, which hopefully will get funding from 2023 onwards. Just for the last 2 minutes, I'll show you the slide that shows you how you can get online with this. So liver tox. If you learn nothing else, and for those who already know about this, you'll know how useful this is. Even I use this all the time. So it's an online resource for anybody interested in DILI. So what it does, it gives you a general overview, and it's got entries. It says 800 there. It's like more like 1,300 now. So it gives you case presentations. So it gives you, okay, you took doxycycline, and you think this patient had an injury from doxycycline. So what does that actually look like? So you can read about it. It gives you what the characteristics are. There's some pathology slides there on some of the cases, and then it links to references and other online resources. And if you're really interested, you can upload your own case onto the website. So this is what it looks like. I have to give Jay Hoofnagel all the credit because he put this together, and it's a very useful resource. Gets millions of hits every month. So basically, you can search for your drug, and it will give you, as I mentioned, essentially several pages of literature on this and what the injury should look like. So I'll sum up now. So the take-home message should be that DILI is common if you describe it as kind of like mildly elevated liver enzymes, but severe injury is actually quite rare. We've identified like several genetic risk factors, mainly in the HLA region, chromosome 6, but there are other polymorphisms in other genes, as well as I mentioned, these modifying genes that we'll have more information on as we get more cases. Making a diagnosis is still a bit difficult because we have to exclude everything else. These kind of computerized scores, this RUCAM and RECAM, will be useful. Everybody likes to have an app on their phone, right? So if you can put that in and come up with a score, that would probably be useful. This is kind of where we're going, as well as a network, the HDS, because people like that, the government likes it, FDA likes it as well. That we have several interesting findings already with legal ramifications and implications. And liver tox, if you take nothing else away, visit liver tox because it's a very useful website. Just to acknowledge some people. So at Sinai, it's myself, Joe, Odin, Priya, Greywood, and our coordinator is Umair, and in DILIN, Jay Hoofnagel is really the mastermind behind all of this, but lots of eminent people at other institutions. And if you have cases of DILI, please email myself or Joe. So even if you suspect, it's easy for me just to look up in Epic. If you have a patient that you think has got a liver injury and you think it might be DILI from whatever, please just email me, and I'll definitely respond. And I'll stop there and take questions.
Excellent. Thank you so much. I mean, this was fascinating, although a little bit scary at the same time. We'll open the floor to questions. I think there are a couple in the chat that came during your talk. Let's see if you answered these.
Yeah, from Dr. Berger.
That was about getting cases into the registry.
Yeah, so the way we do it, even if we're not on site, it's relatively easy for us to get the data. We basically need kind of obviously talk to the patient, and we need like 3 tubes of blood. Even if we can't, it's just useful information to have. So just by all means, just email myself or Joe. If you have a case that even if it turns out not to be DILI, it's okay. I mean, I say much rather we can discuss and we don't enroll.
Yeah, thank you. That's very helpful, Dr. Weissman. If I could follow up with a
yes. I was
different question. Yeah, As I listened, I put that in very early because I was a little shocked that we have this great registry here. And yet down at Beth Israel, where I know myself and many of my colleagues can say we've either had suspected or clinically diagnosed DILI that sort of did self-resolve and we kind of moved on. To me, in an informatics sort of world, and it's wonderful to see the that last website, the liver diagnosis website you put up there, that we're not using more of this. Like these are like a lot of the things you're mentioning are sort of things people talk a lot about, like, oh yeah, doxycycline can cause this or that. And maybe you see one, or maybe you see some mild stuff. But I think that, you know, we do a poor job of collecting all this. And when I think of the power of Sinai and the healthcare system and the reach, is there a way that we could be better about building up the not a registry of rare cases, but almost some sort of living, breathing registry that's really interactive and that we're kind of getting people the best care in real time, not only banking their blood and all the other stuff, but making sure we're always doing the best and the right thing for them. Because we'll often look to our local expertise, which is great, but now hearing about these other resources, is there a way that we could harness the power of the system to do more in things that are probably more common than we think, but everybody kind of writes it off as a 1 in a million case when it's probably not?
No, I agree. So this is only one example, right, DILI? There's multiple other examples in liver for us. I don't know from a system-wide approach how we could do it better. I mean, one thing is just knowing about it, right? So we have people that partly COVID has also played a role, that we would have twice a year, like a CME type conference. And this is how people email me or call me if they have a suspected liver injury, because they just know about it, that we're interested in it. So it's just getting out there and letting people know. As I say, we check email all the time. So if you email me, I will respond within, I would say, 5 or 10 minutes if you have something that you want to discuss. So this isn't not just for DILI. Now, doing it in a more kind of a systematic way on a system-wide, I'm open to suggestions how we could do that best.
Great. Thank you so much. Justin, do you have a question?
Yeah, thank you so much. This was really helpful, Dr. Ahmad. One thing you had mentioned was the Chinese herbal supplements, and I've seen 2 cases here related to that. And one of the challenges I've had is, 1, figuring out what's in the supplement, and 2, figuring out, like, I think on the list, even on liver tox, it's sometimes hard to find, you know, if there's really a strong relationship with these Chinese supplements, especially when we haven't found another source of the DILI. And do you know if there's been any like collaboration, like in places where the use of these supplements is higher, like in China, possibly, where we have good numbers on like some of these supplements and their relationship to DILI?
Yeah. So first part of your question about making that diagnosis. So if you have those cases, for instance, what we try and do is get the sample, get the thing that they took, right? Because then we can actually analyze it. The language barrier, we have like Mandarin and Cantonese, like consent forms. So we can enroll patients, and we have enrolled patients with these Chinese herbal supplements. But that's a whole nother kettle of fish, right? Because the what's in those things, we only really will know if we're able to analyze them. Because even for the compounds made over here or in Europe. In terms of collaboration, we have not done that with China. We have collaborations with people in Europe and with people in South Asia, right? So in India. Again, I'm open to, and if you look at the literature, the Chinese publish a lot on this stuff, and so we just haven't. And they have their own kind of national registry, even on a local basis. And South America has one, Europe has, the Spanish have one. We haven't done that, and that's maybe something that we should think about.
Thank you.
And then Dr. Risk asked a question in the chat about people locally who are doing studies on supplements, and how would we access that? Talia, did you want to ask that directly?
Oh, yeah, no, because we actually I had 2 cases of vitamin D toxicity, and it's the same thing. We sent the specimens. One was like a muscle milk. The manufacturer of this supplement actually was taking his own supplement, and he got toxicity. And another guy came in. He was actually the guy that made the Vidal Sassoon movie. He overdosed on vitamin D. For the labeling and concentration issue, we only learned when we sent it to a lab up at Mass General, this guy that was a guru in vitamin D. And it was a big lesson for me to hear exactly what you're saying, is that none of these are FDA regulated. None of it, we don't really know what's in the supplements. We don't know the concentration, the labeling errors. It's like a big black box. And
you're right. So this will only, again, I was going to say politics aside, but you can't really put it aside. This will only change it when Congress acts, right? And Congress won't act because there are vested interests in the people who manufacture this stuff.
Is there anybody locally, like you mentioned the lab in Mississippi? I think many of us have patients on these supplements and are often wondering, what is in them. And I've collected things from patients and have not really known what to do with them.
Say we don't have anybody locally that I'm aware of that's doing this, because it's actually very labor intensive and it's expensive. So the person in Mississippi, that's essentially their role. It's the national natural product something. But we've been collaborating with about 10 years, and one of our, again, we have 6 centers. One of the centers is particularly interested in this, so he spearheaded like a repository of these things. So if you have cases and you have the compound particularly, that's very useful, because then we can send it off and you'll get some data back about what was actually in it.
Very interesting. Thanks.
All right, Dr. Harrington.
Yes. Thank you, Dr. Ahmad. This is a really, really interesting topic, obviously very clinically relevant. I think one of the things that you really covered extensively in this talk was how DILI is a diagnosis of exclusion. And you mentioned that, to firmly make the diagnosis, other etiologies of acute liver injury must be eliminated. And so my question for you is, from a high value care standpoint, is all of that workup required in every case? I'm specifically thinking of, some of the more kind of workup for maybe more rare autoimmune etiologies, some of the more esoteric lab values that, take a very long time to go and may cost a lot of money. If we have a case in which we suspect DILI, maybe we have one of the agents that you showed as being a relatively frequent or common cause of it. If we have a case in which we sort of suspect DILI, do we need to do this, extensive workup for esoteric etiologies?
No is the answer. So it will depend on, it's a little bit of a case-by-case basis, right? So for instance, if you have a patient that took Augmentin, right, and had a cholestatic injury, right, outflows of 800, Billy goes up. The likelihood that that's going to be acute hepatitis C is going to be very low, right? So there's really no need to get hepatitis C RNA. Probably HCV antibodies enough. There's no need to do hepatitis E testing, right? So hepatitis E testing in the last, 3-4 years, it's more, you can get it on EPIC, not the RNA, but you definitely do the antibody and IgM as well. So it's probably not necessary. But if you have a case that's hepatocellular, right, you really need to do hepatitis C RNA test. Because again, we published on this, but you think, okay, there's no risk factor, but it was probably from the dentist or probably from some sort of other procedure the patient had somewhere locally that they got acute hepatitis C, because there's evidence that we had serial studies actually on these patients that we stored sera that showed that it was an acute hepatitis C. Similarly, if you have a cholestatic injury, you probably should get better imaging than just like an ultrasound, particularly if it's not getting better, right? Because maybe there's damage to the biliary tree, so you probably should do an MR. So it will be based on, you're right, what the type of injury it is and what you think is the suspect drug, right? So similarly, INH, right? The patient has got latent TB and is on INH and has an acute hepatocellular injury with jaundice. They don't really need an MRI, all right? They don't need an MRCP. So you don't need to do, we do it purely because it's a research study, right? So we want as much data as we can. But in terms of for you, and this will be for the RECAM when it comes out, you'll see when you input the data, you basically get slightly higher points. But for you to make a diagnosis, you've already reached that because you had a drug that's classic injury and you had the correct latency. So the added points you get because you excluded X, Y, and Z doesn't actually help you that much because you already made the diagnosis.
Thank you very much.
Thank you so much. Any other questions, comments from the audience? All right.
All right. Well, thank you
Great.
so much for joining us. We really appreciate it.
Thank you. Please email me, right, for anything. Okay.
Will do. Take care.
Thank you so much,
Thanks.
Dr. Ahmad, for the amazing and very informative talk. Thank you so much.
Thank you. Take care.